Today, we have the privilege of having two speakers. One is Dr. Anas Alani, who's an associate professor of medicine at Loma Linda University, California. He's a non-invasive cardiologist specializing in cardiac CT. We also have the Matthew Budoff, who is the endowed chair of preventive cardiology at the Lundquist Institute at UCLA. He is, in my opinion, the world's expert in cardiac CT, and we have the privilege of hearing him talk about cardiac CT and the use in prevention. He's written over 50 books and 1,000 articles and numerous research grants and numerous accolades from multiple different societies. Again, this is going to be recorded, or this is being recorded. It'll be available on the California ACC website after the presentations. Without further ado, I'd like to introduce Dr. Budoff.
Well, thank you so much, John, and it's certainly an honor to be here and talking to all of you. For background, John Baker was my senior fellow when I started my training, and Anas was one of my CT fellows, actually. So it's all part of the small world here. But anyway, let me take you through where we are with cardiac CT in 2025, and then we'll open it up for some case discussions with Dr. Alani, and then we'll have time for Q&A, I'm sure. So use my conflicts of interest. So I wanted to start with cardiac CT, but I think the story starts with coronary artery calcification. And I just wanted to take this from the American Heart Association's statement back in the year 2000, so now 25 years ago. Coronary artery calcification is part of the development of atherosclerosis. It occurs exclusively in the atherosclerotic arteries and is absent in the normal vessel wall. It's a strong, independent, and incremental predictor of adverse cardiovascular outcomes. So, given that intro, really a very simple test, a test that requires no contrast, no IV, 30 seconds at most. Patients can be dressed as they are and get a scan and find out if they have plaques building up in their coronary arteries. Bob Detrano, who is a senior investigator at my institution at Harbor UCLA and then went on to UC Irvine, demonstrated that it's the strongest predictor of future MI and cardiac death that we've had in a long time. If you have no coronary calcium, what we call the power of zero, with absence of atherosclerosis, you have a very low risk. If you have a little bit of coronary calcium, it's just a volume of calcified plaque in the coronaries. You have a 4-fold increased risk of events. Calcium score above 100 is a 10-fold increased risk. And a calcium score above 300 is a 14-fold increased risk of non-fatal MI or cardiac death. So think about that. When Dr. Ridker tells us about C-reactive protein, he says CRP is an independent predictor of cardiovascular events with a hazard ratio of 1.17. We're talking about now a hazard ratio of 10. So literally 100-fold more predictive than C-reactive protein. Where could we use this test in clinical practice? Well, if we took intermediate risk patients with a Framingham score between 10 and 20% 10-year risk, and we did a coronary calcium score on them, and we looked at how many patients got upclassified, the answer would be about 14%, or about 1 in 7 would not be intermediate risk, they'd be high risk. But more important than that, if we found out that 2/3 of those patients that we thought were intermediate risk had no plaque in their arteries and were actually low risk, and this is net reclassification, which means that it requires us to be event driven. So this is per events. 2/3 of those patients that we thought were intermediate risk were actually low risk. And we could de-risk those patients. So a lot of people look at coronary calcium and risk, and they're like, you know what? If somebody has high cholesterol or cardiac risk factors, I want to put them on a statin because I want to prevent heart disease from ever occurring. Can we really do primordial prevention with statins? Can we prevent atherosclerosis? So this is a study of almost 20,000 patients out of Walter Reed, followed for 12 years. So it's not a randomized trial, it's an observational study. But 12,000 patients, 23,000 patients, but followed for 12 years. So look at this, patients with a calcium score of 0. This represents 9,360 patients, so almost 10,000 patients followed for over a decade. If they had on a statin, they were in the red line. If they were not on a statin, they were represented here as a blue line. And you can see now a line that is so superimposed that there's absolutely no benefit from being on a statin. The p-value was 0.99. The hazard ratio was 1.00. And if you look closely, the only way they could annotate this in the journal was by putting a dashed blue line and red line, because the event rate was exactly the same. The number needed to treat, infinity. Literally, you'd have to treat an infinite number of patients to see a benefit for statin therapy with a calcium score of 0. So these are calcium score of 0, 9,360 patients, 0% benefit from being on a statin. So you'd say, okay, statins didn't work in a calcium score of 0. It imparted no benefit. The event rates were exactly the same. But did statins really work in this population? Well, let's take a look at the population of patients that are advocated to be on a statin. Patients with a calcium score above 100. These are the curves. Red line represents patients on a statin. Blue line represents patients not on a statin. Again, observational data, but closed healthcare system, the Army, long-term follow-up, 12 years, and 100% patients follow-up. So excellent follow-up. And look at the curve separation. At 5 years, if your calcium score was above 100 and you were not on a statin, you had 32% more events than those patients on a statin. At 12 years, the event reduction was 68%. 68%. Look at the red line as compared to the blue line. The number needed to treat, 12. We treat 12 patients with a statin with a calcium score above 100, and one of them does not have a heart attack, cardiovascular death, or stroke. So we can get a number needed to treat from infinity with a calcium score of 0, no benefit, to a number needed to treat of 12 in patients with a high calcium score. So we have excellent data that a calcium score can delineate who needs to be on therapy. And the guidelines adopted this. In 2018, the prevention guidelines said, if the calcium score is 0, it is reasonable to withhold statin therapy and reassess in 5 to 10 years, as long as higher risk conditions are absent: diabetes mellitus, family history of premature heart disease, or cigarette smoking. Tobacco is an interesting one because smoking doesn't cause atherosclerosis only. It can also cause thrombosis by making you prothrombotic. So tobacco may be an interesting one. Diabetes, obviously, we know the increased risk of cardiovascular events with diabetes. But interestingly, in that Walter Reed study, patients with diabetes had no increased risk if their calcium score was 0. The guidelines also say if calcium score is 100 or higher, or in the 75th percentile or higher, it is reasonable to initiate statin therapy. So calcium score of 100, definitely start a statin. Calcium score of 0, it's reasonable to withhold statin therapy and reassess in 5 years. What about aspirin use? If you understand where to use aspirin and when to use aspirin in primary prevention, you're a much better physician than I am, because I get confused because the US Preventive Task Force every 3 years changes their mind. 10 years ago, every middle-aged person deserved aspirin. 5 years ago, nobody deserved aspirin. Now, some people deserve aspirin for primary prevention. I'm not talking about post-MI or post-stent. So can calcium scoring help us with aspirin use distribution? If we look at the patients who had a 0 score, calcium score of 0 on the left, that red line is patients who had the number needed to harm. So the number needed to harm with a baby aspirin, 81 milligrams, is about 400. You treat 400 patients with 81 milligrams of aspirin, and somebody will have a major bleed. So if those bars are above the red line, that means that the number needed to treat is worse than the number needed to harm, and you're going to do harm. So in a calcium score of 0, whether you're low risk in blue or high risk in red, based on the pooled risk equation or the Framingham risk or the prevention risk calculator, if your calcium score is 0, the number needed to treat is higher than the number needed to harm, and therefore you should not treat with an aspirin. Look at the far right, calcium score above 100. If the calcium score above 100 is whether you're low risk in blue or high risk in red, if your calcium score is above 100, the number needed to treat is about 5 to 8-fold lower than the number needed to harm. So you'll prevent 5 heart attacks or deaths for every 1 major bleed. So 8 different societies, including American Heart, including American Society of Preventive Cardiology, including the National Lipid Association and the Society of Cardiac CT, all advocate that if your calcium score is above 100, you should put patients in primary prevention on 81 milligrams of aspirin. So I did this study to try to identify when does enough coronary calcium warrant secondary prevention treatment. So this was a study called the CONFIRM Registry. It was an observational study. In blue are the event rates if you had a score of 0. Asymptomatic score of 0, very low risk for 7 years. In red, if you had a little bit of coronary calcium, a score of 1 to 99, you had a slight increased risk of events. If your score was over 100, your event rate went up significantly. And if your score was above 300 in purple, you had a quite high event rate, 20% event rate by year 7. So high risk. But look at those patients in yellow. In yellow are patients who had a prior myocardial infarction, who were then followed over the next 7 years, and that was their event rate. And patients with a calcium score above 300 had the exact same event rate as patients who already suffered a myocardial infarction. So an MI represents a bad day in anyone's life. 1/3 of patients die at the time that they have their MI. If you survive an MI, you're the same risk as if you have a calcium score above 300, but have not had an MI. So the new guidelines are now advocating that if your score is above 300, you deserve aggressive therapy as if you've already had a myocardial infarction. But I think the biggest benefit of a calcium score is actually adherence and compliance. We, as preventive cardiologists and as cardiologists in general, advocate that patients take a statin or an ACE inhibitor or an aspirin or whatever therapies we apply for prevention. The problem is that it's easy for us to write a prescription. I can write a prescription in 30 seconds for a year supply of statin or aspirin or ACE inhibitor. The patient has to open up that pill bottle every day, has to pop that pill, has to go to the pharmacy to get refills, and the compliance is not that good. So how can we motivate patients who feel well, asymptomatic patients, to actually take therapy? Dan Berman in Cedars-Sinai did this wonderful study called the Eisner Randomized Control Trial. 2,137 patients, asymptomatic, were randomized to either no scan, they saw a nurse practitioner to get guideline-directed medical therapy based on their blood pressure, their cholesterol, and their ASCVD risk. Or they got randomized to getting a calcium score and cardiovascular risk assessment. And those patients that got a calcium score, the right column that says CACs, had lower LDLs 4 years later, had lower blood pressures, had more use of exercise, more lipid therapy, more blood pressure therapy, more aspirin therapy, and 4 years later were more adherent to their statin therapy. So knowing your calcium score improved outcomes and improved compliance to all of the preventive therapies that we talk about every day. Recently, at the end of 2023, the American Heart Association came out with a presidential advisory on the cardiovascular kidney metabolic health algorithm. And they said, stage 0, you're healthy. Stage 1, you're obese. Stage 2, you have risk factors. But stage 3, the stage before having a cardiovascular event, which is stage 4, was subclinical atherosclerosis. And the only way they defined subclinical atherosclerosis was with a calcium score. If your calcium score was above 0, it favored statin use in intermediate risk. If your calcium score was above 100, it favored aspirin use and considering other therapies like PCSK9s or GLP-1s or icosapent ethyl based on your overall cardiovascular risk assessment. So in 2023, calcium scoring became dogma. It became part of the algorithm of care for assessing cardiovascular risk. Nathan Wong, who's not here tonight, but helps Dr. Baker run this California chapter, came up with this guidelines from India. And I just want to show it to you because I think it's very practical. It may be a little too aggressive, actually, but very practical. You take patients who have a calcium score of 0 in green, and you treat them with lifestyle modification. They have a calcium score, a volume of calcium in the coronaries of 1 to 99, and they're in the less than the 75th percentile, LDL less than 70. They have some athero, but not high risk. If they have a calcium score of 1 to 99 or a calcium score above 100, high risk, and they're above the 75th percentile, you treat them as high risk and you get their LDLs lower. And if they're very high risk, above 300, like I showed you from the confirm registry, you treat them as secondary prevention. David Marin out of Stanford first authored this cohort, this expert consensus document. It was published in JACC Advances last year. Looked at calcium score of 0. They say lifestyle essentials 8. Be healthy. Don't use medical therapy. Calcium score of 1 to 100. Promote AHA Life's Essential 8 and consider and put them on a statin. Calcium score above 100, definitely a statin, consider aspirin. Above 300, absolutely statin, and LDL target now below 55. And LDL and calcium score above 1,000, severe calcifications, all of the above, plus statin, plus emerging therapies, colchicine, icosapent ethyl, GLP-1s. So when we think about where calcium scoring fits in to our preventive algorithms, we have patients who are intermediate risk, an ASCVD risk score of 5 to 20%, or a family history. Remember, we don't know the genome that causes atherosclerosis. But if your parent or your grandparent had heart disease, you might be at increased risk. So we can't rely on genotyping. We have to rely on phenotyping. And that's where the calcium score comes in. I have patients whose dad died at age 45, and I do a calcium score on them, and it's 0. And I say, you probably didn't get the gene from dad. Or I see patients, I had a 38-year-old female who had a terrible family history. Her calcium score was in the 80s. She had the coronaries of a 60 or 70-year-old female, and she was asymptomatic. So I use that to identify who with a family history would benefit from medical therapy. It's remarkable in California how many patients are statin reluctant or intolerant. Dr. Google doesn't help us by telling us about all the side effects of statins. But when you show a patient a calcium score that's high in them, and you know what, Mr. Johnson, you feel well, you have a lot of coronary calcium, they're willing to try a statin. So for those statin reluctant patients, a calcium score goes a long way. Aspirin, it's a no-brainer. We have no idea how to treat patients with high for aspirin in primary prevention. A high calcium score, benefit. A low calcium score, 0 calcium score, no benefit. And I think we can advocate who deserves to be on 81 of aspirin in primary prevention. And for motivation, there is no known better tool. We can get patients to stay on statins, to try statins, to stay on aspirin, to lose weight, and to have better blood pressure control with a calcium score. If you want to put this into your clinical practice, there's what's called the MESA risk calculator, the multi-ethnic study of atherosclerosis. On the right, you can plug in their gender, now we would say sex, their age, their calcium score, their race, ethnicity, all of their risk factors, and you can calculate their risk. And the higher the risk, the more you would go for LDL reduction, the more you would go for aspirin therapy, and the more you would go for additional therapies depending on their cardiovascular risk status. So I'll take you back now 500 years to Machiavelli. Machiavelli said, at the beginning, a disease is easy to cure, but difficult to diagnose. But as time passes, not having been recognized or treated at the outset, it becomes easy to diagnose, but difficult to cure. And I would argue that that's been our path for the last 500 years in cardiology. We wait for patients to get symptomatic. They see a cardiologist, we diagnose them with advanced heart disease, and we put them on a dozen therapies. And there's great therapies to treat them with. But if we could have identified them 5 years earlier, 10 years earlier, and got them on preventive therapy, I think the world would have been a much better place for those patients. Some of them who died with their first presentation of heart disease. But the interest in cardiac CT didn't get born out of calcium scoring. I've been doing calcium scoring since the early 90s, and very few people were interested. But CT angio grasped the interest of cardiologists, because not only could we see who has plaque, but we could see who has stenosis. How tight is the blockage? Where is the blockage? It's a simple test. 0.5 to 0.625 millimeter slices. So thin cuts through the heart. We cut the heart like a loaf of bread, very thin slices, and we can see exactly what's going on in the coronary arteries. It's about a 10-second breath hold. So even those patients with COPD or heart failure can get a CT angio. It does require non-ionic iodinated contrast. And this is important because if they have renal insufficiency or contrast allergy, this might not be a good test for them. The test for most patients, they're in and out within about 20 minutes. It's simple, easier than a treadmill, easier than a stress echo or a nuclear scan. Interpretation, I'd say 5 to 15 minutes. If it's normal, it's pretty easy. If it's advanced, it might take a little longer. So let's go through just quickly where CT angio plays a role in preventive therapy. If the CT angio says there's no stenosis above 50%, the negative predictive value is 99%. That means that they do not have an obstruction and they do not need a cardiac cath. The radiation doses have come down dramatically. We used to talk about 9 to 15 millisieverts for a CT angio. That's 5 years of background radiation at least. And now with 256 CT, we can do CT angiography with just 1 to 3 millisieverts of radiation, below the radiation we get from cosmic rays or from airplane rides or other sources of radiation in our common life. We can see not only the artery, we can see the amount of plaque, and we can see the amount of percent stenosis. So we can quantify the plaque burden, and we can quantify the flow down the vessel. It's more accurate than PET scanning. CT angio is more accurate than SPECT or cardiac MR or stress echo. There's no doubt. I haven't debated this in at least 5 years, that CT angio is more diagnostically accurate than other testing. We see the artery, we can see the blockage, and we can treat them appropriately. But most important, if you've got a CT angio as your diagnostic test instead of a stressed nuclear, you live longer, you have less heart attacks. In Scott Hart, 41% lower death rate and lower MI rate if you had a CT angio first, looking for stenosis and subclinical atherosclerosis, so 20% blockage or 30% blockage, which is important because it can plaque rupture and cause a heart attack. You can't see that on a functional test. The PROMISE trial, exactly the same results. Event rates with CT angio, event rates with functional testing. If you get a CT angio as your first test, patients have less heart attacks and death compared to a stressed nuclear or a treadmill or a stress echo. So when we think about the context and where this fits in, the functional testing failed us miserably in a trial called Ischemia. Ischemia was a study where we said we're going to take patients who have large abnormalities on a nuke or a stress echo or an MRI. And we're going to randomize them to a stent plus optimal medical therapy, what we called the invasive strategy, or just optimal medical therapy called the conservative therapy. And there was no difference. So randomizing patients or treating patients based on an abnormal nuke did not improve outcomes. But worse than that, look at the event rates that occurred in the ischemia study. In blue, patients who had a normal nuke or normal stress echo had more events than those patients who had an abnormal nuke or an abnormal stress echo. And the doctors were blinded to the treatment. So it wasn't that they had an abnormal nuke and they got treated more aggressively. It's just the physiology doesn't equate to outcomes. Look what happened if we stratified risk based on CT angiography. In the ischemia trial, one vessel disease, about 8% of patients had an event. Two vessel disease, almost 12% of patients had an event. Three vessel disease, almost 18% of patients had an event. With a p-value less than 0.001, CT angiography stratified risk better than functional testing. So the guidelines came out in 2021. And in 2021, the chest pain guidelines came out, and they were certified by 7 societies, multi-societal guidelines. For cardiac CT, they simply said CTCA is effective for the diagnosis of coronary disease, for risk stratification, and for guiding treatment decisions. Class of recommendation 1, level of evidence A. So 1A recommendation. CT angio is effective for diagnosing coronary disease, for risk stratification, and guiding treatment decisions. What about functional testing? And this includes treadmill, stress echo, nuke, PET or SPECT, cardiac MR, useful for the diagnosis of myocardial ischemia. Class of recommendation 1B with a hyphen, non-randomized data. What's wrong with this recommendation? Class 1 recommendation. It says useful for the diagnosis of myocardial ischemia. What is it not useful for? Let's go back to the CT recommendation. It's not effective for diagnosing coronary disease, which is why we did the nuke or the stress echo. It's not recommended for risk stratification because it doesn't stratify risk very well. I showed you the ischemia trial, and it doesn't guide treatment decisions. So the most important facets of our decision-making as physicians treating our patient is that a test should guide decision-making. And functional testing does not do that. Functional testing diagnoses myocardial ischemia. And if you don't think that the language between these two is important, I'm going to bring you back to the guidelines. And this is the who signed off on the guidelines. And there's one society that had experts at the table and helped us write the guidelines. And it was called the American Society of Nuclear Cardiology, or ASNC. And they're not listed in the final paper because when the final conclusion was that CT is better than functional testing, including nuclear, they said, we can't put our name on that document. Any document that says nuclear is not the best, we can't participate in. And they pulled their name off the document at the very end. Not that it changed the guidelines at all, but to show you the difference between a recommendation that says that we can guide treatment decisions with cardiac CT and we can't guide treatment decisions based on functional testing. But I would still argue, after all of that, that functional testing is really important. It tells us about ischemia. Is that lesion that I see on the left, that anatomical CT angio, that LAD lesion, right after that little white speck shows a moderate to severe stenosis, is that physiologically significant? So what I had to do in the past was, after my CTA, I'd get a functional test because I needed that information. But now we have a solution. We can take that anatomical test and run it through AI. And with FFR CT, we can diagnose whether or not that mid-LAD lesion is physiologically significant. And in this case, it is. And with that same CT, without additional testing, radiation, or contrast, we can get more information about the physiological significance of that lesion. It's done from a typical CT angio, no additional radiation, no change in imaging protocols, and no additional medications. And if that artery ends up being orange or red, it's bad. And if it ends up being blue, then it's open. The guidelines adopted FFR CT. For CT angio, this is the 2021 chest pain guidelines I just showed you. The ACC/AHA chest pain guidelines. CT angio is the only class 1 non-invasive test with a level of A evidence. But FFR CT is designated as a class 2A evidence set. And what did they say? That it can guide decision-making regarding the use of coronary revascularization. A test that guides decision-making is helpful for us as clinicians. FFR CT guides decision-making. Is it really better than PET or SPECT? This was a head-to-head study called the Pacific study. In blue is FFR CT. The diagnostic accuracy is the highest. The area under the curve for sensitivity and specificity, 0.94. Better than PET, better than CTA, and better than SPECT scanning. So when we think about physiology, plaque, this was a study called the Advanced Decay Study. In green shows patients who had no flow limitations. Their FFR CT was normal. They had abnormal plaque characteristics, and they had late events. 2 years later, they started having events. So if we find subclinical atherosclerosis on our cardiac CT, we can treat them early and hopefully avoid these late events. If their FFR CT is abnormal in red, they have early events because their flow is abnormal and we need to treat them early. And if they're unlucky enough to have a high plaque burden and abnormal FFR CT in red, they have early cardiovascular events. They also have late cardiovascular events because of plaque, and their event rates are quite high. So CT gives us 2 answers, where a SPECT scan gives us 1. We get plaque plus anatomy and physiology. We get, do they have athero? Is it a lot of atherosclerosis? That's plaque. Do they have a high-grade stenosis? That's physiology. So as we think about this and we finish up our concept here, with CT angio, we can identify normal patients with a negative predictive value of 99%. We can identify patients in need of preventive medical therapies, even subclinical atherosclerosis. Put them on a statin, maybe 81 of aspirin, and prevent the disease from progressing. We can look at assessment of both plaque and ischemia, functional data, physiological data with FFRCT, as well as plaque volumes with CT angiography. But it's not a perfect test for sure. There's plenty of patients who should not get a cardiac CT as their first test. If we know they have a crazy amount of coronary calcium, a score above 1,000, we can't read the studies very accurately, and we need to avoid cardiac CT. Stents are not bad with cardiac CT, but if they have many stents or small diameter stents, that poses a problem. CT is a camera. It takes a picture of the arteries as they're moving. And if they're moving too quickly, we can't get a clear image. So we need to make sure that we can get their heart rate under control. And we use beta blockers and we use calcium channel blockers. We even use ivabradine, a funny channel blocker, to get their heart rates under control. If you think they need a cath, then get a cath. We're not going to replace cardiac angiography if they have a high pretest probability of disease. The diabetic, hypertensive who has classic angina, they still need to go to the cath lab. And if they have renal insufficiency or contrast allergy, we don't scan patients with an EGFR below 45 with a CTA, because I give them contrast plus radiation. And if it's abnormal, I got to go to the cath lab and give them contrast plus radiation. And I don't want to do that. But I would argue that the age of functional testing, nuclear imaging, stress echo, treadmill is behind us. It's old medicine that we shouldn't be doing anymore. Because this is a patient of mine. He had diabetes, he had some atypical chest pain. His doctor did a nuke and said, you know what? You're fine. Your nuke is normal. You did well on your exercise test. Don't worry about heart disease. Your chest pain is GI or musculoskeletal. It's not your heart. Don't even worry about it. So he came to see me a few months later, and I said, you know what? You have diabetes. You had some atypical pain. You're still having some atypical pain. Let's get a CTA just to make sure. And the CT angio was not discordant. It didn't show that the nuke was wrong, but it showed that he had a ton of subclinical atherosclerosis, a ton of arteries that were filled with 30 to 50% plaques. And instead of saying, you know what, you're fine, I said, you know what, it's not so good a result. You have severe atherosclerosis. You need a statin and a high potency statin. You need aspirin therapy, 81 milligrams. You need to work on lifestyle. And if you get some chest pain, a twinge, a pressure, you come running to me or to the hospital because your arteries are not clear. The nuclear was wrong. The assessment was wrong. Yes, you don't need a stent. The nuclear was correct. But the concept that you're reassured that you're doing okay is completely wrong. And we need to move away from functional testing because it gives us the wrong answer too often. I'll leave you with this thought. Arthur Schopenhauer was a philosopher of the last century. All truth passes through three stages. First, it is ridiculed. Second, it is violently opposed. Third, is accepted as being self-evident. And I would argue that, at least with calcium scoring and CTA, we're finally coming around to the concept that seeing subclinical atherosclerosis, early plaque, is going to be useful. That we don't want to just do a functional test and say you don't need a stent, but I have no idea if you have a 30% stenosis. That's the wrong answer, and that's the wrong test, and we can do better. So I'll stop at this point. Thank you all for participating, and I apologize for being a couple minutes late. And I'm going to turn it over to Dr. Alani to take us through some case studies.
Outstanding presentation. If anyone wants to ask questions, feel free to write them down in the chat. We'll have some time at the end to go over those. Dr. Alani?
Okay, perfect. Let me just share my screen. Can you see my slides?
Yes.
Okay, so yeah, thank you very much, Dr. Budok. This is an excellent presentation, and it's very hard actually to follow such a great presentation. But I'll present some basically practical cases, kind of to emphasize basically what Dr. Budok said. It will take me just a few minutes to go over the cases. Will be very brief. So this is a 46-year-old female with a past medical history of hypertension, prediabetes, family history, obese. She has some hyperlipidemia. Her 10-year risk was 6%, so it's an intermediate risk. So this is where calcium score will come kind of a good test that you can use to risk stratify this patient and see if she can benefit from more like a statin and more therapy. I mean, I was hoping the calcium score would come 0, so we can reassure the patient defer a statin, but the calcium score came to be 96, 98 percentile. So this patient started on a statin. We show her the picture. She was now more, motivated to use the statin, more motivated to lose weight, and kind of following healthy diet. So excellent use of calcium score in the intermediate risk patient.
Something went wrong. Please try again.
This is a 96-year-old male with some risk factors, hyperlipidemia, prostate cancer. His 10-year risk was high at 15%, but he was hesitant to start statin. And this is common. I face it in my practice. Patient maybe try some statin, maybe they are hesitant. And so I use calcium score, as Dr. Budok mentioned. This is to kind of see where they lie. You will hope statin will come, calcium score will come 0, so you can defer statin. But some life example, like the calcium score came to be low at 7. So this is where come, the shared decision. You can tell them statin may be reasonable. Overall, their risk is low. So this patient decided not to start statin. The third case is a 57-year-old male with the past medical history of diabetes, good control, hypertension, hyperlipidemia. He's obese, a lot of risk factors. You can follow his LDL through the years, sometimes high, improved, then later, get higher. He's on Crestor. I mean, he's kind of okay following the guideline, but you would like kind of to know more. So in my practice, I use statin even for the patient who had diabetes to know if there is any more room for improvement. So his calcium score came to be 540. So this patient is high risk. In spite of his LDL is reasonable, his hemoglobin A1C is reasonable, but this patient is higher risk. So I did increase his statin. I added aspirin. His calcium score is more than 100. And previously he was hesitant to start on GLP-1 agonist, but now he's more willing to try. So again, more motivation, and it helped kind of to guide my therapy. The fourth case is a female, 60 years old with a diabetes, family history, multiple family members who had an MI and coronary stents. She's very anxious. She had 2 functional testing. The first one was submaximal stress echo, and then she had a nuclear stress, negative for ischemia. Patient is still very anxious because she had a strong family history. So I ordered a coronary CT. Didn't come free vessel disease, but it come with a normal coronaries. So this is just to emphasize, I think, how I can reassure the patient that in spite of your family history, in spite of your risk, I can reassure you, as Dr. Bullock mentioned, you don't have the genes from your family, and then kind of more confident about what I'm telling the patient. The last case is a 50-year-old male with risk factors. His 10-year risk was borderline 5%. He did have some chest pain. He had a stress echo that was negative. As Dr. Budov mentioned, like we tell the patient, you are doing well, no need for a statin. Few years later, patient got older, more obese. He's continued to have some on and off statin. He underwent a cardiac cath. It came to be with mild non-obstructive CAD. Patient was told you are doing fine. Low-dose statin was initiated. Few years later, patient continued to have atypical chest pain. Coronary CT was ordered. Patient had an extensive coronary plaques, high risk of plaques. So we did lose like 5 years, several years, like 3 years of the opportunity kind of to work with the patient. And then now this patient is higher risk, while previously by stress echo, by cath, he was classified as a low risk. This patient, I see him more frequently while he did lose the follow-up for a few years. And then he ended up actually on PCSK9 because we couldn't lower his LDL to the goal. I think this is the end of my cases. I can stop sharing.
Thank you very much. They're excellent presentations. I think they're very, very, very provocative as to what we should be doing with coronary calcium and coronary artery screening with coronary artery disease. So as we wait for the question, I have a question for actually both of you. Back in the days when we would do screening, when coronary calcium was not very not a widely spread use, we had stress echo and we had nuclear. So those were the two tests, and it was very specific that if your lab, so like for example, William Beaumont does tons of stress echoes, and so other institutions do tons of nuclear, your sensitivity and specificity were significantly different depending on which institution that you were in. Does cardiac CT, the cardiac CT angiogram, and also the cardiac coronary artery calcium scans, are those reproducible among centers? Meaning that if non-university centers, community hospitals, can you rely on the results of a cardiac CT scan or a CTA in institutions that are, again, don't do a lot of these procedures? How reproducible are they? And excluding the FFR, CTFR.
That's great question, John. And I'll start by saying that the calcium score is remarkably portable. So that means that they actually did a study in Germany where they took patients and they did a calcium score in one city and a blood pressure. And they went to another city. They took those patients and they did a blood pressure and a calcium score again. And the calcium score was more portable or more reproducible than the blood pressure measurement. So calcium scoring is uniform across the world. It's the same Agatston score that we use everywhere. But CT angiography is based on the expertise of the reader. And that's the same with stress echo and the same with nuclear. If you have a poor reader who's reading CT or nuke or stress echo, their results may not be very reproducible. The nice thing is that FFR CT is done by a central lab in San Francisco, HeartFlow, or other companies, but it's all done the same way with the same algorithms. So I think calcium scoring and FFR CT are quite reproducible. CT angio is somewhat dependent on the expertise of the reader and what we call local expertise. So when we did the PROMISE trial, we did a study where we said you have to get a CTA or a functional test, but the functional test was only based upon local expertise. So if you were at Beaumont, you did a stress echo. If you're at Cedars-Sinai, you did a stress nuclear. You did what you do best. So local expertise still plays a major role. I don't know if Anas has other comments.
Yeah, no, I definitely echo what you said. I think practically, I think it's hard to miss like a three vessel disease by coronary CT. I mean, you might miss like a diag, you might miss, like an ostial circ, like one lesion. It's harder to miss two lesions, but I think missing three lesions or like multiple lesions will be harder by CT, unless you kind of read completely the wrong study. But I think, for example, nuclear. I mean, there is the risk of balanced ischemia. I mean, no matter how good you are in nuclear, this is the limitation of the test. Like if you show it like to a lot of people, this nuclear stress test is normal. I mean, there is no doubt about that. Just like the limitation of the test with the balanced ischemia. I think left main disease also, I mean, it's a big artery. I mean, we do focus on left main, so it's also, I think I would say, harder to miss. I mean, I've seen some people miss left main, but I mean, it's the biggest artery, so easier to kind of pick on CT. So I would say CT, you can pick bad disease easier rather than nuclear is the limitation of the test itself.
Excellent. Okay, so we have a few audience questions here. So Paymon has a great question. Is that any indication to get calcium score in low risk patients and high lipoprotein(a)?
So keep in mind, and I didn't talk about it, but I should have, a limitation of coronary calcium scanning is age below 40 or 45, where it's really not as reliable. So if you have a young person who has a high Lp(a) and you're nervous, you're going to have to do a CT angio. I think Lp(a) is tough. I think the penetration of disease is like LDL. So not everybody with high LDL gets atherosclerosis, and you just don't know how it's going to penetrate in that individual. So you need to do something. So I use it for Lp(a) elevations. We don't have good treatment for Lp(a) yet. Hopefully the Horizon trial from Novartis will show us some guidance there, but we really don't know what to do with, I think, with Lp(a) as much as we should. That's a debate for another day maybe, but I'm not that clear on how to use Lp(a) in my practice yet. As far as low risk patients, the problem is if you're low risk, the number needed to scan. So we always talk about the number needed to treat. The number needed to treat is how many people we have to give a atorvastatin to prevent a heart attack. The number needed to scan, how many patients do we need to do a calcium score on to actually change their management? And if they're very low risk, the number needed to scan is high. In other words, we have to scan a lot of people to change one person. So I think low risk is low risk, and we should treat them as such. Intermediate risk, high risk, I think CT or calcium scoring helps us in that management.
Outstanding. So yeah, everybody feel free to ask questions. You've got, like I said, the world's expert here in this field. Another question from Dr. Unzek. Great presentation. Thank you, Dr. Budoff. Can you talk a little about plaque composition, burden, and composition analysis?
Yeah, so, when we do the CT, we can see non-calcified plaque, including low attenuation or vulnerable plaque. We can see non-calcified plaque in the form of fibrofatty plaque or fibrous plaque. So we definitely can, based on the density of the plaque, we can see different amounts of atherosclerosis and different types of atherosclerosis. And the quantitative plaque assessments, clearly, or heart flow plaque, can quantify the millimeters cubed of plaque that we have in each of these categories. We can't do that visually. And give us an idea of who has a lot of vulnerable plaque or who has a lot of stable plaque. That requires AI, and we have a couple companies that have it available. And I would tell you, within a year, there'll be 6 or 7 companies that are FDA approved to measure plaque volumes on cardiac CT. So it'll become quite commonplace and quite easy to do.
Excellent. Dr. Gigaloo has a couple questions. If you'd like, you can go ahead and unmute yourself if you would go ahead and like to ask your question live. Or I'll ask him for you. You can do it on your next one.
Hello, can you guys hear me?
Oh, we hear? Yes,
Yeah,
we can hear you fine.
you.
Go ahead.
Yes. Thanks, Dr. Buddha, for the great presentation. I'm one of the CTMR readers practicing in Orange County. So for someone with, let's say, a calcium score of 50, but the calcium is located in left main versus someone with the same calcium score of 50 whose calcium is in distal RCA, would you consider any difference in management, or you just go purely by the number or maybe the symptom of the patient? I guess that's my one. Yeah, go ahead.
Sure. Let me start with that one. We did a lot of research trying to figure out if LAD calcium was worse than right coronary calcium or circumflex calcium. It doesn't seem to matter as much, but in your question, left main calcium is probably worse. There's something about calcification in the left main that portends a worse prognosis and a higher likelihood of obstructive coronary disease. So left main calcium is different than the others, but LAD is not worse. The LAD, the widowmaker, is not worse than the circ or the right coronary, but left main is worse than any of the others.
Gotcha. And I guess my next question is for any symptomatic patients with, let's say, less than 50% stenosis, 25 to 49% on coronary CTA, would you ever consider, let's say, a functional test on these symptomatic patients, or you just try to up-titrate GDMT and treat them as a stable ischemic heart disease? Is there any point of doing any, let's say, nuclear or stress echo on someone with, let's say, mild to moderate disease?
Yeah, no, it's a great question. So, if they have extensive diffuse 25 to 50%, 25 to 49% stenosis, so their whole LAD looks terrible. There was a FFR CT, the fractional flow reserve, did a study called the Advance Registry, and they found in about a third of those patients, they had flow limiting lesions. So I would say if you see extensive diffuse athero and you don't think anything looks critical, they may still have the culmination of multiple lesions going down that vessel may lead to decreased blood flow. And I would think about doing a functional test or an FFR CT if they have diffuse extensive subclinical athero.
Gotcha. Thank you so much, Dr. Buddha.
No, thank you. It's great to hear from you.
Okay, Dr. Lani, did you have anything to add?
Yeah, I think, and then for the second question to add, at least in my practice, if I see, a patient coming with, typical chest pain and the coronary CT just mild, of course, I have to look at the CT myself, look nothing was missed. And then sometimes you have to go to the route of the microvascular angina. So functional testing might come like handy, as Dr. Budov. Patient typical angina, but they don't have obstructive CAD. When you think of vasospastic microvascular angina.
Another question that came up is, actually this comes up quite frequently. So if you have someone with a coronary artery calcium score of just say X, just say it's 110, whatever it is, and you treat them with something, statin, you're doing something with that. Is there any value to repeating your coronary CT angio? I understood there's a value of if you have your coronary calcium score is 0, then you repeat it again to see if it turns into a number where you would treat. But if it's already elevated, is there a value at repeating coronary CT or actually coronary calcium score?
No, it's a great question, John. And I think we need to learn more about this still. I've been doing this for a long time and still trying to validate the concept of serial calcium scores. But I think if you go from a score of 20 and you test them 3 years later and their score is 110, they're definitely in a higher risk category and probably deserve more aggressive therapy. If their score is 150 and it goes above 300 or 400, they've definitely moved up in risk. Once they're above 300, there's no rational reason to ever test them again. And actually, sometimes testing can just derail therapy, because I've seen patients who have scores of like 1,000 and they come back in for a repeat test and now it's 1,200. And is that the effect of the statin calcifying the vessels and making it more dense and slowly raising the score? Or is that my failure to treat? But there's no way to figure that out. So I think if you're going to reclassify patients 0, 100, 300, there may be some value. Above that, there's no value that I can think of. I don't know if Dr. Alani has other thoughts.
No, I think I agree. I think practical point, I don't repeat a lot of calcium. I mean, I try kind of to do aggressive management like from the beginning. I might go sometimes for coronary CT, like kind of as the next step, like with the contrast, just kind of to assess if there is any more, high risk plaque that, of course, the calcium score doesn't pick. But I don't repeat a lot of coronary calcium scores.
Okay, two other questions. So one, so calcium scoring, it was your slide about the calcium scoring of over 300 is equal to the patients who with coronary artery disease. That's very, very compelling. So the flip side of that question, if you have a patient with established coronary artery disease, just say they've had stents, myocardial infarctions, et cetera, is there any value of getting calcium score on that particular population? And then the second part of that question, actually, I'll stop there. I'll answer.
I would just say no. In general, if you have established ASCVD, you don't need a calcium score anymore. You know the answer. You know how to be aggressive. We should be very aggressive. I don't think a calcium score is going to change your management.
Okay. Fine. No other questions there. Okay. And then the second part of the question is that if you have somebody who is at low risk and has a calcium score, or just someone who's at low risk and they have calcium scores of just intermediate calcium scores, not high risk, not anything that's going to alarm a patient. Or actually, let me back up one. So if you have a patient who's just concerned about his heart disease, just saying, I don't know, I'm asymptomatic. I want to know what my risk of heart attack is. No symptoms, no family history, no anything. Who would you recommend getting calcium screens on? All the patients who show up into a cardiology office, or just patients who are interested and they're looking at their risk of coronary disease?
I mean, I think if you have a patient who doesn't have known coronary disease and they have at least some risk factors, I think a calcium score helps a lot. It's a simple test. My boss and your boss, John, Bruce Brundage, when we started in cardiology, called it the mammogram of the heart. He said that we're going to be able to determine who has early disease, like a mammography. And if it's negative, you don't worry about the problem. And if it's positive, you start going down that diagnostic road. And I think it's very, very helpful. So if they have intermediate risk or higher and they're asymptomatic, I think a calcium score at least is helpful. Some people would even advocate a CT angio, depending on their cardiovascular risk factors. I think that's premature in primary prevention, but I think that there's some utility in knowing where are they in that spectrum of heart disease. Do they have none? Do they have a ton? Or they're somewhere in the middle, and we can treat them differently based on the results of the scan. Any test that guides treatment decision is an important test. And calcium scoring, CT angiography, and even FFRCT, based on the guidelines, guides treatment decisions. And that's important.
Great answer. Dr. Lani, Dr. Budoff, anything you wanted to add to?
Yeah,
Right.
I just want to ask Dr. Budoff one question about the confusing aspirin, just kind of to know his insight. I see a lot of patients in the clinic who have been on aspirin for a long time. They are getting older, they are, falling, their risk of bleeding getting higher. So do you use calcium score to guide if you can maybe stop aspirin? Like patient coming to you, they've been on aspirin for a long time. and then they want to stop it, and calcium score is like 0 or very low.
Yeah, I have to say, I stop statins, or I give them the option of stopping statins if the score is 0. I give them an option of stopping aspirin if the score is below 100. And I think that's where our guidelines are today. So I think it helps me a lot clarify where people are in the spectrum of disease. And again, looking at it, we all know, we've looked at a patient, they look like a train wreck, they're smokers, they're fat, they're overweight, they have a little bit of diabetes. We do a cath on them, their coronaries are perfectly normal. We have other people who, marathon runners, they're healthy as can be, they look fit, and their coronaries are a disaster. So we can't predict based on the outward appearance of a patient, and we need to do some screening. It's crazy. We screen for lung cancer, the number 2 cause of death. We screen for colon cancer, the number 3 cause of death. We screen for breast cancer, the number 12 cause of death. And we don't screen for heart disease, the number 1 cause of death in men and women. It's just insane. It doesn't even make sense. There's no way you can even rationalize that algorithm of care that we have. We have to do cardiac screening, whether it's a calcium score or a CTA, or maybe, you're a Paul Ridker disciple and you want to do CRP or LP(a). But we need to figure out who's going to die of heart disease, because that's the number 1 killer. And all the other things should be secondary. But our medicine in the US is a little bit upside down still. We'll get there, but it's taking too long.
Matt, I actually love your statement of the cardiac CAC is the mammogram of the heart. So I think I want to use
That's Bruce
that.
Brundage, not me,
Really?
please.
Oh, okay.
My chief of cardiology when I started, he said that. That's not me. I won't steal from Bruce, but
Gotcha, Bruce.
I love that concept. Yep.
I agree. Yes, I do too. Any closing thoughts, Dr. Budo?
No, I think I just gave you my closing thoughts. I'll leave it to Dr. Alani to close us out.
Yeah, no, I think, I use calcium score in my practice, and also I use like CT chest. So, we have, Epic now. Almost all the patients did have like a CT at one point. And actually, even further, I actually even open the CT abdomen, because, you will be surprised, but half of the heart, even sometimes they cover all the heart. So I always looked at any CT. If the patient showed up in my clinic, any CT chest, CT abdomen, I will open it and look for coronary calcifications.
Outstanding. Well, we thank everyone for participating and coming to our webinar. I want to thank the speakers. Excellent talk. Kind of just a great overview of cardiac CT, in my opinion. The next one is we have these seminars every second Wednesday of the month. So the same link that you use to join will join you for the second one. All you have to do is kind of just sign up, click the little button. So again, the second Wednesday of every month, we'll have our next meeting is going to be on prevention of heart failure. So again, look forward to seeing you at our next meeting, and thank you for coming.